Thank you very much. Thank you, Jacek, and I'm really. It's gonna be a very difficult for me to be on the podium right after Arnold Kaplan, and but I try to do my best. So my topic is I'm gonna talk about the stromal vascular fraction and discuss when, why, and how we can use this potential to treat osteoarthritis. So. Mm, Sorry, my slides do not move. Okay, so why is it important? Why we should find new ways to treat osteoarthritis? This is mainly because, as you can see on this slide, osteoarthritis is not anymore a disease of older people, like in 90s and past. It was usually a disease for older people. Now we see an explosion of osteoarthritis in younger and middle-aged people, and definitely the techniques that we have developed for treatment of osteoarthritis are not very good for younger and active patients. Why is it like this? It's because we know that the current classical treatment for osteoarthritis, which is total knee replacement, works very good, but for older people. And if you look at the results of total knee replacement in 40 or 50 year old people, especially in male patients, the results of such treatment are really bad, and we see that there is a high risk of the revision and the failure of this treatment. So this is why we should use the new techniques. We should use the biologics before we even start thinking about doing a surgery, because we know that arthroscopy, the debridement are not so good for osteoarthritis, and this should not be a first-line treatment for the osteoarthritis. What are the possibilities? I think that when you look for the potential cell-based therapies for osteoarthritis, we have a large options. We have many possibilities. So as you can see, there is there are different sources for stem cells and for other cells that could be used for cartilage treatment. And I'm going to just focus on one of them, which is the adipose-derived MSCs. I think that this is something that Arnold mentioned just in his presentation, and I want to come back to this because I think that this is very important, especially for my own perspective, because I have traveled to Arnold lab more than 20 years ago to study the cell-based therapies and study mesenchymal stem cells potential for cartilage repair. And even though we were successful together with Arnold to regenerate the cartilage with MSCs in a rabbit model, but I think that we can expect some regeneration. But most of the things that we know about MSCs are based on a lab models of tissue regeneration. In fact, as Arnold mentioned, there is no such things like mesenchymal stem cells, because all those cells that we used to think about like they are stem cells, they are actually the pericytes. So those cells are spread all over our bodies. They are sitting on capillaries, and those cells have a potential for regeneration of other tissues, but not in a way that they can differentiate into other tissues, but they are like a mobile pharmacy that's secreting the growth factors that can stimulate other cells for regeneration. So I'd like to mention this scheme. This is a publication from Arnold and his co-workers. about the MSC's use and the potential therapeutics. And I'm just gonna bring your attention to some little part of this slide, which is showing different ways of stimulating the potential of MSCs, and depending on which receptor they are stimulated by, they can express immunomodulatory response or trophic effect. But you can even see that they have a antimicrobial effect, so they can secrete local antibiotics. So this is a very potential cell. But if you look at the literature, it's very hard to find the clear evidence. Why is that? Because there are so many, as you can see, there are so many different cells being used. You can see the publication showing the primary cells or culture expanded cells. You can see the cells isolated by mechanical or enzymatic digestion. You can see some evidence for either allogenic stem cells or autologous stem cells. They can be harvested from adipose, from bone marrow, from umbilical cord blood, for peripheral blood. And of course, there are different ways how we can deliver the cells. We can deliver them in just like in PRP or in their own niche in adipose, for example, tissue, or resuspended in hyaluronic acid. So this is very difficult to get clear evidence. But if you look at the literature, the literature is growing up, and I think we can find enough evidence. For example, this is a list of different publications showing the evidence for MSC's injections. Some other publications I'd like to highlight. This is one of the first publication from Dr. Wakitani from Japan, who was also a student of Arnold Kaplan, like myself. And so he used the culture expanded MSCs, and he combined the injection of those cells with the knee osteotomy. And he showed the successful regeneration of extensive unicompartmental degenerative changes in the knee. So you can see in a lower panel, 3 slides low, they show control group. You see some regeneration, but you can clearly see in the histology that the regeneration of cartilage when the patients received the injection of MSCs, the quality of the tissue was superior to the control group. Another example, evidence for injections of MSCs when the HTO was combined with microfractures, and again, superior results showing the tissue formation. And so you can see this was both proven on the MRI and in histology. And this is an example from this group. You see histology samples showing superior quality of the regenerated tissue. Another example, percutaneous cell injections without surgical treatment. Again, this is a 24 weeks post-injection observational study, and it was showing the evidence for an improvement. Another study coming from the researchers showing using the autologous bone marrow aspirate concentrate in 41 patients, improvement in VAS score, improvement in IKDC score, and improvement in quality of life measured by SF36 score, and also the Lisholm score improvement. Another study. This is the study looking for the bone marrow. For the adipose-derived MSCs at 12 months follow-up, showing a improvement in the degemerik MRI score. So how does this work? So we see there's an evidence showing that the MSCs respond to inflammatory surroundings. So when they are placed in the for example, osteoarthritic joint, they exhibit immunomodulatory and anti-inflammatory and anti-fibrotic effect, and this is done by the release of the paracrine mediators secreted by those cells. So, what is osteoarthritis? I think that most of us who are orthopedics, we used to think about osteoarthritis as a mechanical disease. Of course, there are mechanical risk factors like joint trauma or overuse or obesity, malalignment. These all factors can lead to pathophysiological processes, but in fact, those processes that are exerted inside the joint, they include severe inflammatory and immune events, and those events are based on the secretion of various types of immune cells, including monocytes, mast cells, T and B cells, and all those cells infiltrate the synovial membrane and fat bed, and they secrete vast amounts of pro-inflammatory cytokines that are distracting the joint. One of such factors is substance P. Substance P is secreted by sensory nerve fibers in the synovium and infrapatellar fat bed. And substance P is associated with pain pathways, and it's a key modulator for local immune and inflammatory and fibrotic response. And the effect on the immune response by substance P is based on modulation of the cell proliferation and activation and a migration of those cells to the sites of inflammation and expression of several chemokines and adhesion molecules. And the substance P receptor, the neurokinin 1, is expressed inside the joint in synoviocytes, and it regulates the expression of matrix metalloproteinases, which are the enzymes that degrade articular cartilage, and this is responsible for degradation of the joint. And another player in this game is it's called CD10. It's a neprilysin, and this is the factor. This is endopeptidase, and it's expressed by MSCs and immune system. And this factor has a strong enzymatic activity which neutralizes substance P. So this is natural neutralizer of the substance P. And what is important, there's a very, very strong direct relationship between CD10 and substance P in context of synovium and infrapatellar fat inflammation. So this is a potential involvement of either resident joint MSCs or injected MSCs as a source of CD10, which could be a neutralizer of substance P. So by this we can say that MSCs can not only be responsible for pain control, but also MSCs can stop the immune-related responses, and it can be a disease modifying agent and stop the progression of osteoarthritis. So this is another example showing the pain control by stem cells. You can see that this is an experiment on a rat model of persistent pain, and it proves that the bone marrow MSCs injection reverse the pain hypersensitivity, and it was proven that this effect is related on the peripheral and central opioid receptors. So there is a direct evidence showing that also, this is the way that MSCs can stop the pain related to osteoarthritis. Another experiment showing it's a mouse model of osteoarthritis. The mouse had removed medial meniscus, and this is a natural progression to osteoarthritis. And in these experiments, it was proven that MSCs had a significant reduction of pain, but also significant reduction of cartilage proteoglycan loss and structural damage to cartilage. So again, if you think about the possible treatment for osteoarthritis, it looks like MSCs can be ideal source, not only the symptom modifying drug, which would be a pain control, but also a disease modifying drug by the way that they can stop the progression of matrix metalloproteases. So from the technical point of view, what would be my preference for MSCs therapy in my patients? I think that the fat seems to be an excellent source of MSCs because it's very economical harvest, but also it's an excellent source of MSCs. You can expect much higher concentration of MSCs in fat that comparing to bone marrow. And also adipose tissue is an excellent scaffold. When you think about the implantation of MSCs into a knee joint, which is for example, osteoarthritic joint, you can clearly see that there is a benefit from cells being encapsulated in their own niche, which acts as a protection from the local enzymes that could potentially kill the cells after injection. So what is the stromal vascular fraction? This is the fraction of stem cells and other cells that are within the white adipose tissue, and 2% of those white adipose tissue cells that they have potential similar to stem cells. So this is why we call them MSCs cells. So technically, the way that I implant those cells is I use the so-called ACP SVF treatment, which is combination of autologous conditioned plasma mixed with stromal vascular fraction. So as you can see on the left side, the fat is a mixture of different types of cells, and what we do is we reduce the amount of adipocytes, but we leave a cocktail of different cells. I think there is a strong evidence in the literature that when you inject the combination of different types of cells, the response is much higher than if you would use the pure population of one single type of cells. So the cocktail works much better than the pure population. And the technique that I'm using is the simple concentration of the cells. So we have the same number of MSCs, but they are 4 to 5 times more concentrated in a less volume. So there's no need to inject the large volume of cells. We can have the concentration of the pellet size of the cells. So the results I'm going to show is something that I did a couple of years before. This is a study based on the 100 patients with Kellgren-Lawrence 1, 2, and 3. I believe that this type of treatment is ideal for early osteoarthritis. I don't think that, of course, we can expect some pain improvement in grade 4 Kellgren-Lawrence osteoarthritis, but I think that the best improvement is when you can use it on a younger patients and much earlier, because then you can expect some disease modifying effect of MSCs. Those patients that had no mechanical symptoms, so there was no malalignment, there was no problems with range of motion, there was no loose bodies inside the joint. They did not have any other treatment within 12 months before injection, no steroids, no HA injection, no joint modifying surgeries before. A mean BMI was 30, and the mean age of the patients was 57, and they received one single injection of autologous conditioned plasma and SVF in the knee. And this is these are the results. You can see the patients, the overall improvement on the left panel. You see improvement in pain score for 2 years since the injection. But of course, we did not see this shocking difference when you see that the pain, the VAS scores drops down from 5 to maybe 3 or 2. But if you look at when we subdivided the groups and we had the patients with VAS score over 5 and less than 5, you can clearly see that those you can see the much better improvement in terms of the pain. Why is that? Because the group of the patients that I have treated, as you have seen, some of them were grade 1 or grade 2 Kellgren-Lawrence, so they were not so painful, and sometimes they were just concerned with other symptoms of osteoarthritis different than pain. But when you look at the pain, which is high, I think you can clearly see much better the difference and improvement in pain. This is the KUS symptom score. Again, significant improvement in both groups, and overall on the left panel. This is an improvement in activities of daily living of the KUS subscore. Again, significant improvement overall. And if you differ this for the different pain levels, again the WOMAC function score, again significant improvement in all groups of patients. So definitely, I think we need more studies to that are controlled trials of the intra-articular injections for osteoarthritis. We don't know exactly what are the number of injections. I think that every one of us agrees that if you are sick, if you take an aspirin, one tablet of aspirin cannot fix whole problem. So I think that we could potentially develop the therapies that are based on several injections over the years. Looking at my data, I think that you can expect an improvement from one injection up to 2 or 3 years. So I think we should plan and discuss with the patients the several injections. They need to understand that this is not one single treatment. This is not regenerative therapy. This is a pain and disease modifying therapy. And I think that we need to also understand that MSCs work similarly to PRP. And I think that also I'm developing now my therapies the way that I discuss with the patient potential PRP injections after injection of MSCs. I think that the PRP can also mobilize the local MSCs and also help to MSCs to do their job. Again, some interesting examples of the an experimental techniques that I have used with MSCs. This is the study showing the SVF is not only successful for osteoarthritis but also in tendinopathies. And I'm going to show you some examples of the patients that were treated with SVF with autologous conditioned plasma injection for chronic patellar tendonitis. This is the tennis player started with Vascular 8 before the treatment, and you can see before at 4 weeks, 8 months, and 13 months gradual improvement not only in pain level but also, as you can see, there was clear evidence for the regeneration and improvement of the quality of the tissue. Professor Domżalski mentioned earlier today about the ACP tendo, which is Vergenix, which is collagen combined with growth factors. I think that there is also potential to add to this combination a stromal vascular fraction as a source of these cells. I'm going to skip this. So yeah, this is an example showing the injection of the collagen mixed with with ACP and cells inside the chronic degenerative meniscus tear. This is the patient that had implantation of this combination intraoperatively together at the same time with the meniscus sutures. And this is the follow-up on this patient. And again, this also opens the possibility for the injection, which are done non-operatively. This is the injection on the ultrasound guidance. You see injection of SVF together with collagen, with Vergenix inside the chronic degenerative meniscus tear. And this is the follow-up on this patient. So on the left side, you see MRI before the treatment, and on the right side, 6 weeks after injection. You can see clearly that there is a meniscus cyst that is not present on the right side panel. Probably this is due to the fact that this cyst was result of the leakage of the joint fluid through the torn meniscus. Thank you very much, and I look forward to the questions.